surgeon from the University of Toronto, where I work, who has taken a great interest in this problem, and he collaborated with me in the presentation of these slides. I want you to remember that the foot is inherently an unstable structure. If you think about how the foot is built, it's a series of bones built on top of each other, held together with ligaments. We have, in our first paper on Lisfranc dislocation over 30 years ago, brought forward the concept of the Roman arch, and I'll show you an example of that in a moment, where because of the bone structure at Lisfranc's joint, there is some inherent bone stability. And this bone stability is the reason that virtually all of these dislocations are associated with a fracture, even though the fracture may be subtle. And we have to remember that the stability of the foot depends largely on the ligaments, and the ligaments are the strongest on the plantar aspect of the foot. And that also explains, along with the bony anatomy, why most of these dislocations are dorsal rather than plantar. You can see this little diagrammatic example of the ligaments. It's significant that there's no ligament between the first and second metatarsal shaft, but the ligament to the second metatarsal shaft comes from the medial cuneiform. So there's no ligament between the first and second metatarsal. The stability of the second metatarsal relies largely on the bony anatomy between the medial and lateral cuneiform and the base of the second metatarsal. And in this diagram from our original article, you can see how the shape of the second metatarsal is that of the keystone in a Roman arch. If you look at the second metatarsal, the dorsal surface is always wider than the plantar surface. So it looks like a wedge fitting down here, and this resists any pressure for the metatarsal to go in a plantar direction. And this is very important in the overall understanding of these injuries. So here are two things I want to emphasize. First of all, no ligament between the first and second, and secondly, this bony contour. And the second point is that we looked at a number of foot injuries some years ago, published our work in which we looked at polytrauma patients who had a foot injury. So we looked at polytrauma patients with foot injuries versus polytrauma patients without foot injury. And without exception, those patients, polytrauma patients with a foot injury, were more disabled than those patients without. And in many cases, the most disabling problem was their foot injury, whether it was a calcaneal fracture, a Lisfranc injury, a talus fracture. So even in the face of polytrauma, meticulous attention to foot injuries is essential for a satisfactory outcome for these patients. Now here's a CT scan, and you can see the base of the second metatarsal recessed or proximal to the medial and lateral cuneiform, articulating with the middle or intermediate cuneiform. And this is the key, this anatomy is the key to understanding these injuries, because the way this second metatarsal is recessed into the cuneiform is what gives the medial side of the foot its stability. And any treatment for these Lisfranc injuries has to make sure that this relationship is restored. Now, one of the problems with Lisfranc injury is radiographic interpretation. And here you can see there's a gap, obviously, between the first and second. And the second metatarsal is displaced lateral in relationship to the medial cuneiform. And remember, there's no ligament here. The ligament is here. So you would expect to see the gap in this area. And there's a lack of congruency in the shape and lines drawn here around the first metatarsal. So in subtle injuries, you should look for parallelism between these two lines. The two lines should be parallel, not straight, but parallel. You have to suspect this injury based on the history and physical examination of the patient. And these injuries, in my experience, are frequently missed in the emergency department of local hospitals because the emergency room physicians are not aware of the injury, and radiologists who look at the films are often not aware of the injury. And what this typical story is, someone has a slip and fall accident, they twist their foot, twist their ankle, and they come to the emergency department because they have a painful swollen foot. And because they're not appropriately examined, they often don't get appropriate x-rays. And I'm sure all of you in the room have had the experience of seeing patients with fifth metatarsal-based fractures picked up on an ankle x-ray because the patient was not appropriately examined. And in our institution, unfortunately, we see a number of patients presenting late with this injury because they have not been appropriately investigated by history and physical examination. Now, if you suspect the injury, you should, if the injury is not obvious on the plain x-ray, try and obtain x-rays standing. And I'll show you an example of this. If you get a weight-bearing x-ray of the foot, it'll often make this injury more obvious. And of course, a CT scan will help you make the diagnosis. So here's an example. You can see getting the two x-rays. When you first look at this x-ray, the injury may be not so obvious. It's obvious to you because you know I'm giving you a talk on Lisfranc injuries, but if I was giving you a talk on big toe fractures, you might miss that. But you can see if you compare the two, there's definitely a difference between both sides. And on the CT scan, particularly in this view, you can see this tiny flake of bone from the second metatarsal. And now that you've been reminded of the ligamentous structure of the foot, seeing this little flake of bone from here makes perfect sense. A little flake of bone off the medial cuneiform, a little flake of bone off the second metatarsal. You'd expect that because that is the ligamentous anatomy of this part of the foot. Now, the natural history of this injury is poor. And if the patient's not treated appropriately, they often present late with pain and deformity. And this is an example. You see the collapse through the tarsal-metatarsal joint and the abduction of the forefoot in relationship to the hind foot because of a neglected injury. So making the diagnosis and having the appropriate treatment is essential to a satisfactory outcome for these patients. Now, what is the treatment? Initially, when maybe 40 years ago, we treated these patients with a reduction and plaster immobilization, non-weight bearing, highly unsatisfactory because of recurrence of deformity in the plaster. So then we started with reduction, percutaneous fixation with K-wires and plaster, again, high recurrence rate. So now it's well accepted that internal fixation of these injuries should be done by means of screws. The argument now is whether we should do reduction and fixation or should we do primary arthrodesis. Currently, our thinking is that an injury such as this, less than 3 months old, can be treated by reduction and fixation with screws. And the screws we usually remove after some months. Injuries such as this that are older than 6 months, we feel should be treated by arthrodesis. We think that there's an improved outcome for these patients. The real argument is what do you do between 3 and 6 months? It seems a shame to fuse somebody's foot 10 days after they've had an injury if you think they could have a satisfactory outcome from simple reduction and fixation. So we still think there's a role for reduction and fixation early. There's no role for it late. But what about in between? This paper was just published last month. It's a randomized trial of Lisfranc injuries, all less than 3 months old. They randomized the patients to either fixation or fusion. And then at 24 months, they analyzed these patients. And there was no difference between the two groups of patients. But the editorial comment was what would be the long-term fate of this reduction and fixation group. Maybe they're going to go on inevitably to develop a painful arthritis and would have been better off with arthrodesis. And increasingly, we're thinking that primary arthrodesis is the most appropriate way to approach these injuries. Here's an example, a 45-year-old female, simple tennis injury, swollen foot. Plantar bruise, I find, is a very good clinical sign. If you look at the plantar surface of the foot, if they have a bruise, they've had a significant ligamentous injury. And here's the x-ray. Here you can see the slight increase in this area. This is the same CT as I showed you earlier. And what we want to fix is the base of the second metatarsal back to the cuneiform. And this is the dorsal approach that we use. You can see this instrument is in the gap between the second metatarsal and the cuneiform. And we've fixed this with 2 screws between the medial and intermediate cuneiform, and then 1 screw from the first metatarsal into the second, another screw from the medial cuneiform into the second. So this is a very stable, solid way of performing the internal fixation. Now here's a later case, 30-year-old male, had a fall from a height. You can see on the x-ray that there's incongruity between the base of the first metatarsal and the medial cuneiform, as well as a gap between the first and second, and a gap between the medial cuneiform and the second metatarsal. And there you can see a small flake of bone in that area, a pathognomonic of instability. Now this shows a good example of examining the patient. You see there's minimal fullness on the medial side of the foot with the patient sitting. But as soon as the patient stands up, there's an obvious abduction of the forefoot because of the ligamentous instability. Here are the x-rays taken with the patient simply lying on the x-ray table. And here's the x-ray taken with the patient standing. And you can see the obvious displacement through this joint even at 9 months. And there's the treatment by means of arthrodesis. So in summary, the diagnosis may be difficult, but if you have a high degree of suspicion, you can make the diagnosis. Secondly, the surgical treatment is essential. Third, everyone now accepts that screw fixation for the medial pillar is recommended. Anything other than screw fixation is too unstable. I think acute injury less than 3 months, we continue to treat by open reduction internal fixation. Chronic injury greater than 6 months, fusion. 3 to 6 months, I think fusion is more reliable. And increasingly, we're thinking of arthrodesis as the primary operation, even for the acute injury. Thank you very much.